everyone, and welcome to today's live presentation, Biomarkers to Discriminate Bacterial and Viral Infections, presented by Ephraim Tsalik, MD, Ph.D., Associate Professor of Medicine, Department of Molecular Genetics and Microbiology, Duke University School of Medicine. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do this, just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom center of your screen, or use the Ask a Question box to let us know that you're having a problem. Additionally, this presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Now, please join me in welcoming Dr. Tsalik. I will now turn the presentation over to him. Dr. Tsalik, the floor is yours.
Great, thank you so much, and thank you all for joining today. And what I'd like to tell you about today is a little bit of where things stand in the discrimination of bacterial and viral infections, and in particular, the role of biomarkers to aid in that process. So the context for this rests largely with acute respiratory illness. And the reason is because acute respiratory illness, or ARI, is the syndrome in which bacterial and viral etiologies are most commonly present and the etiologies for. Obviously, things like meningitis and encephalitis or gastrointestinal illness can also have overlap with respect to having both bacterial and viral etiologies. But acute respiratory illnesses are by far the most prevalent and the most common cause for patients to seek care. And the most common scenario in which an inability to discriminate bacterial and viral infections leads to antibiotic overuse. Respiratory tract infections cause more than 3 million deaths globally and 164 million disability-adjusted life years lost annually. And again, that's also on a global scale. And the reason that I bring that up is while most respiratory illnesses are mild, the common cold being the most typical example, respiratory tract infections can also cause significant morbidity and mortality. And so it leads to a lot of concern among providers that they be treated appropriately. And if there's a choice between undertreating or overtreating, the statistics would say that most people end up getting overtreated. Specifically, the majority of acute respiratory illness is viral, and yet up to 75% of all ambulatory care visits end with prescriptions for antibacterials. So we know that patients are getting antibiotics inappropriately, and that has consequences. It increases antibiotic resistance, and that's become a significant concern with a number of alarms sounding, both nationally as well as internationally. It increases costs of care, in part for the cost of the medication, but also for the management of adverse effects related to those medications, to those antibiotics. Among patients presenting to emergency rooms for drug-related side effects, antibiotics are the second most common reason, the first being anticoagulants. And so there are real harms that come along with antibiotic use, in particular inappropriate antibiotic use. There was a study that came out now in 2015, although this group, the EPIC consortium, continues to put out papers. EPIC was a CDC-sponsored study that focused on the etiology of pneumonia in the community. This is a multi-site study that asked about the microbiological etiology of pneumonia. And in order to do so, they employed some pretty extensive microbiological phenotyping. They performed standard things like sputum culture, blood culture, antigen testing, but they also employed a lot of research modalities, for example, serologies for a variety of different pathogens, PCR-based detection, to really try and develop the most comprehensive understanding of the etiologies of pneumonia among patients in the U.S. And they had two papers, and I've pulled a couple of figures from each of them, one focused on adults, one focused on children. The notable thing among adults is that despite that extensive microbiological testing, the majority of patients, 62%, had no pathogen identified. And that doesn't mean that they didn't have an infection, but that the infections were caused by pathogens that we lacked the ability to identify. Interestingly, of the ones where pathogens were identified, the majority were viral. 22% of cases with pneumonia only had a viral pathogen identified. 2% more had more than one virus identified. 3% had a bacterial and a viral pathogen identified. And so only 11% of patients with pneumonia had a bacterial pathogen identified exclusively, which is in contrast to the way that most people treat community-acquired pneumonia and what we assume to be true of community-acquired pneumonia, that it is by far most commonly caused by bacteria and other pathogens like viruses and fungus causing a minority of cases. But this study shed some light on that. Of course, it may be difficult to know what that 62% is, and those may very well be bacterial pathogens that our techniques lack the ability to identify. It may also be the case that if bacterial pathogens are difficult to identify, that perhaps a lot of those cases of viral pneumonia also had a concurrent bacterial pathogen. So there's still a lot that's unknown and uncertain about this. In the pediatric population, we see a little bit of a different set of findings, particularly among the youngest groups. The rate at which pathogens and the rate at which no pathogen was identified was much lower. You can see in that group of children less than 2 years old that it was just over 10%. That white box at the very top was the no pathogen identified group. And so in the majority of children, a pathogen is being identified. And of the pathogens that are being found, most of them are viral. Across all age groups, viral or more than one viral pathogen was found in about 2/3 of cases. And in the youngest group, that was or approximately 80% of cases of viral, at least one viral pathogen was identified. And really in only a small number of cases was a bacterial pathogen identified or even a bacterial and viral co-detection. So it suggests that in children with pneumonia, again, the same caveats apply in terms of our ability to find all of the different etiologic agents of pneumonia, but viruses seem to be playing a much more prominent role among children with pneumonia. Continuing on with this, the top figure here is the one I had just showed you, but to break it down in terms of what the viruses are, it does vary by age group, and in the oldest age group, that pie chart all the way on the right, the 10 to 17-year-olds, that tends to mimic the types of pathogens that you see in the adult population as well. But in the youngest groups, you see RSV and rhinovirus being the most commonly identified. Metapneumovirus is commonly identified. Adenovirus, parainfluenza virus, influenza, and then coronavirus, and then strep pneumo sort of round out the groups. And so the assumption of these sorts of studies is that if we are trying to differentiate between bacterial and viral pathogens, then finding the pathogen must indicate what the nature of the disease is. And there are some limitations with that, not the least of which is the fact that pathogen identification strategies are of limited sensitivity. For example, in the adult version of the EPIC study, the majority of patients had no pathogen identified. And so that makes it very difficult to extrapolate whether or not those patients have a bacterial pathogen that might need antibiotics or a viral pathogen that really won't benefit from antibiotics. And some of the different approaches that one might take, now to get into some of the specific tests, are, for example, rapid antigen tests. These are some of the oldest tests that we've had at our disposal. These include things like rapid strep, rapid flu. And just to highlight some of the strengths and limitations, here I'll present to you the rapid antigen tests for influenza. Typically, these detect influenza A and influenza B. They don't subtype, although clinically it may not necessarily be that important to subtype in terms of determining whether or not to treat a patient with Tamiflu, for example. The nice thing is that they're fast, they're relatively affordable. The specificity is quite good, 90 to 95% specific. So if you have a positive result, it's one you can assume is likely to be real. But the sensitivity is highly limited. And in particular, this was most noteworthy in the 2009 H1N1 outbreak, where the existing rapid antigen tests were of such low sensitivity that there were recommendations against their use. Sensitivity continues to be quite variable. It's certainly improved, and we can see numbers in the as high as 70%, but it still has some limitations. The figure that you see there in the middle of the panel here indicates what the positive and negative predictive values are, and really highlights the fact that flu testing, particularly with an imperfect test, is highly dependent on where you are in the season. And so, for example, if it's not in the midst of flu season and you were to run a test, even a positive test does not have that good of a positive predictive value, not even reaching 80%. But if you are in flu season, a negative test result, particularly with these rapid antigen tests, does not by any means exclude the possibility of influenza, where you see that negative predictive value dropping only as low as 80% in the midst of a flu outbreak, of a flu season. And so the table on the bottom, again, highlights some of those numbers and compares different types of etiology testing for influenza, including rapid antigen, fluorescence antibodies, and a respiratory viral panel. We'll talk about some of those a little bit later on. But again, it highlights that sensitivity can be quite poor. The specificity is high, meaning if you get a positive result, it's a pretty useful test. If you get a negative result, it can sometimes be a meaningless test, depending on that particular test that you're using. There are newer generation rapid antigen tests for influenza, and a couple of them I've identified here. One of them is the BD Veritor and the Quidel Sophia. In these cases, the sensitivities are a bit better, ranging anywhere from the 60s to the high 80s. Specificities are also pretty high, in most cases, greater than 95%. And this is true of both. The BD is a little bit better in terms of sensitivity than the Quidel, but both of these, again, offer relatively rapid results, reasonably affordable, and are generally conducive to use in a primary care environment. Another rapid antigen test example is RSV. In this case, I won't go into the details, but the numbers here are very similar to what you see for influenza. Again, the two digital point-of-care assays that are identified here are the BD and the Quidel. What about Group A strep? This is another one that's very commonly used in a primary care or an outpatient environment. And there was a meta-analysis of these different, in particular, these different platforms, the Solana, the Liat Lab in a Tube, the Sophia, and the QuickView. And those are the Quidel products. What you can see here is that the pooled sensitivity across all of these was 86 to 91%, and the pooled specificity was in the mid to high 90s. So those are, again, pretty good. All things considered, it's still useful to think about the pretest probability, and at times people will use the Centaur clinical criteria in order to gauge the likelihood that strep is present. And that's useful because if strep is extremely unlikely to be present, then a positive result may end up being a false positive. And if strep is extremely likely to be present, a negative result doesn't necessarily exclude the existence of disease. So it's important to bear in mind the performance characteristics of these tests. But again, given these sensitivities and specificities, they can be quite useful, particularly in an outpatient environment. And so other pathogen identification approaches beyond rapid antigen tests include sputum culture. And what I'll do is I'll highlight one particular study here. This is a study of about 1,700 patients with community-acquired pneumonia. And what the purpose of the study was to determine the frequency with which sputum culture ultimately provided useful information. So of that group of 1,700 patients, only 59% of them were actually able to provide any sputum sample at all for analysis. Of those, only about half of them were considered of good quality, based on the presence of neutrophils, based on the absence of epithelial cells. Of that group, only about a half of them had a quality and a predominant morphotype in terms of bacterial cells that were identified on gram stain. And then those ultimately yielded a positive culture in 86% of cases. The yield in culture was only 20% in cases that had a good quality specimen, but without a predominant morphotype. And so when you boil all that down, what you find is that a good quality sputum with a predominant morphotype was only present in about 14% of patients with community-acquired pneumonia. The likelihood of getting a good quality specimen was independent of pneumonia severity. And it really highlights the fact that sputum culture is of use and is particularly helpful, and it's positive, but it's going to be unlikely to be helpful in the vast majority of cases of community-acquired pneumonia. Then we've got urine antigen tests. And in particular, these exist primarily for Legionella as well as Streptococcus pneumoniae. The urine antigen tests are likewise relatively fast and simple to perform. A meta-analysis of 27 studies focusing specifically on the binacs for the urinary strep pneumonia test. And what they did is they used culture as the reference standard, found that it only had a 69% sensitivity and specificity of 84%. Now, this is a common pattern where we see high specificity and lower sensitivity. Again, in this case, a sensitivity of 69% does not exclude the existence of pneumococcal pneumonia with a negative test, but a specificity of 84% also doesn't necessarily mean that if positive, pneumococcal or Streptococcus pneumoniae is the pathogen. And in particular, children, especially those under 12 years of age, are known to have high rates of carriage and of shedding with positive pneumococcal antigen tests in the absence of symptoms. So specificity is particularly low in a pediatric population, such that this test is not usually performed in that group. The numbers for Legionella are a bit higher, particularly the specificity, and that's largely because there are low rates of asymptomatic carriage of Legionella. And in this case, these numbers were based on a meta-analysis of 30 studies. And they used 6 different methods to assess those, 32 different assays. Okay, moving on from urine antigen testing to NAATS, which are nucleic acid amplification tests. These generally come in 2 flavors, single target or posse analyte, meaning that they're really only targeting one or a few pathogens, and then multiplex panel, of which there are a variety of different versions that are made. Some of them are identified here. The BioFire, Luminex, GenMark, Nanosphere are all different examples of these. Things to highlight here, these are some of the FDA-cleared NAATS that have targeted panels, meaning that they are either focusing on one or just a few pathogens. You can see the different types of viruses that are detected in these. Most of them focus on flu. Beyond that, RSV is often the next one to be added on, and then after that, there are a handful of viruses that are added on. Sensitivity and specificity for these viruses are generally quite good. You see numbers for both sensitivity and specificity that are in the 90s and reaching 100% in some cases. There are some exceptions to that. For example, in the Focus Simplexa, their Influenza B assay has sensitivities that have been reported to be a little bit on the low side, but quite a range, up to 100%. Likewise with the Prodessa, the RSV is a little bit lower, but still at 89.5%. Parainfluenza, 89%. Those are still pretty good, especially when you compare them to antigen-based tests. So these nucleic acid amplification tests, many of which can be fairly rapid, do offer quite significant improvements in sensitivity and specificity over the antigen tests. Among the multiplex panel, here again are 4 of them I've identified. And what you can see here are the distribution of different pathogens that are targeted by these. Many of the viruses are the same. in terms of the different panels: Influenza A, Influenza B, RSV, parainfluenza virus, metapneumovirus, rhinovirus are all targeted by these. In some cases, enterovirus is identified at the same time as rhinovirus, given their similarities. Coronavirus in the case of two of these, adenovirus. And then some of these also include bacterial pathogens. So, for example, the biofire includes pertussis and parapertussis, chlamydia pneumonia and mycoplasma pneumonia. The nanosphere RP-Flex includes Bordetella. You can see the Luminex also includes a couple of bacterial pathogens. The input for these is typically a nasopharyngeal sample. And it's worth pointing out that particularly for patients with lower respiratory tract infections, a nasopharyngeal sample can sometimes lead to a lower likelihood of recovery of the pathogen. And that's something that's known to impact all of these tests. That's not so much a test characteristic, but more a function of the physiology. I didn't go over the numbers for these in terms of sensitivity and specificity because they're very similar to what you see with the smaller panels of nucleic acid amplification tests. Again, they tend to be quite high, generally 90% and above. Now, one of the limitations with pathogen detection assays is the question of carriage versus infection. And I alluded to this in the case of pneumococcal pneumonia. And here's one study that highlights that. This was a study that looked at 200 children ages 3 to 7. They were all asymptomatic. They enrolled them at 9 different daycare centers, and they obtained NP swabs just to detect whether or not these individuals had pneumococcal carriage in their nares, and then also simultaneously assessed whether or not pneumococcal antigen was present in a urine antigen assay. Well, you can see that there is, to some degree, a function of age. Age group that had carriage was about the 4-year-old age group. But in general, it was around 44 to 60% had carriage of pneumococcus in the nasopharynx. And the frequency with which these children shed pneumococcal antigen in their urine and had a positive assay was quite high as 39% in the youngest age group, declining to 18% by the time they were 6 years old. And this just really highlights why this particular test is infrequently used in a pediatric population because of the high rate of false positives, even in asymptomatic children. Well, the same also goes for viruses. This was a study called the Big Love study. This is one that looked to identify the presence of viral pathogens in families in Utah over the course of about 1 year. And in each of these different boxes is a different pathogen that was targeted. They used the BioFire film array to measure these different viruses. Families were sampled longitudinally, generally getting a sample about once a week. And in each of these plots, you see different numbers on the x-axis, and those numbers correspond to the duration of shedding in weeks. And the other thing to point out is there's in each of those different bars, there's a darker section on the bottom and a lighter section on the top. That corresponds to whether or not virus was detected at a time that the patient was symptomatic. And so the darker sections, so if we, for example, if we go to the top left, the bocavirus section, there were 151 episodes in which bocavirus was detected in this population. The majority of patients who had bocavirus detection had it detected for a limited period of time, just 1 week around the time of a respiratory illness. But of that group, only about 46% were symptomatic. The remainder of those cases had detectable bocavirus, but at times that they had no symptoms. For rhinovirus, you see similarly high rates of symptomatic and asymptomatic shedding. The same goes for adenovirus, where 40% of adenoviral detection occurred in patients who had no symptoms. And you could see those same trends for most of these viruses. Some tend to be less common. One of the coronaviruses, it's hard to extrapolate. It only had 2 cases. Most of the other corona strains did have a significant number of asymptomatic shedding. Among cases of metapneumovirus and influenza, you did tend to see more cases associated with symptomatic illness than with asymptomatic illness. But even with influenza, you're seeing detection of influenza in people who don't have symptoms. Some of the parainfluenza viruses had almost no association with symptoms, parainfluenza 3 and 4, though again, the numbers for those cases are quite small. What this really highlights, and the point I want to make, is that if you have somebody who presents and they are sick, and you do one of these pathogen detection tests and it comes out positive, would it have come out positive even if the patient was asymptomatic? Is that someone who simply has the presence of a virus, but that is not associated with the symptoms that they're coming in with, or is that actually the cause of their symptoms? If you're just as likely to find rhinovirus in someone who's sick as someone who isn't sick, what does it mean then when you find rhinovirus in somebody who has pneumonia or who has a respiratory tract infection? So this is undoubtedly one of the challenges associated with these pathogen detection strategies. In this slide, this is the EPIC study again. We had started off the presentation talking about, and this is just another study that highlights this point. In this case, they had just over 1,000 patients with community-acquired pneumonia, and then 759 patients that they identified as asymptomatic controls. And they compared the rates of identification of different viruses in controls versus those who had pneumonia. In the top panel is a focus on children. And what you can see is that a quarter of children, 24.4%, who were asymptomatic, had a virus detected, whereas that number was 68.8% among children with community-acquired pneumonia. So certainly you're more likely to get a virus identified when you're sick than when you're not, but that's still a significant number of patients without symptoms who have a virus detectable. You can see rhinovirus, those numbers are pretty similar, 17 in asymptomatic versus 22 in pneumonia. But for others, for example, RSV and metapneumovirus, if you find the virus, there's a pretty good bet that that's what's causing your illness, just given in this study the low rate of carriage in asymptomatic children. In adults, the story was very different. Only 2% of adults out of 238 of asymptomatic adults had a virus detected, compared to almost a quarter of adults with community-acquired pneumonia had a viral pathogen identified. And so it's much more likely that if you're an adult and you have a viral pathogen identified, that is likely to be the cause of your illness, just given the known low frequency of carriage and shedding in an asymptomatic adult population. And so given the challenges associated with detecting pathogens and then interpreting the results, can we learn more by looking at how the host responds to the infection? So again, sometimes you may have low sensitivity, sometimes it may be low specificity, it may be a long time to result, or there may be uncertainty as to how to interpret a positive or a negative result. And those are all problems that different pathogen detection strategies have. Some have strengths, but each one of them has certain limitations. And so is it possible to learn more by focusing on the host? Now, the ideal biomarker in terms of a host biomarker to help discriminate viral and bacterial infection would be one that is rapid, and the time to get to a result depends a little bit on your testing environment. If you're thinking about somewhere downstream, we're certainly not there yet, but somewhere downstream where you might have home testing or potentially field testing in resource-limited environments, a test that is very rapid, occurring within a few minutes, is ideal. In an outpatient environment, there really isn't time to run a test that takes longer than 20 minutes. If you're in an ER, a test that takes an hour is tolerable. And if it's a hospitalized patient, there are many tests that are ordered that take significantly longer to get a result, in which case there's a little bit more tolerance for a longer time to result. But ideally, it should be as quick as possible. A low complexity test that's easy to perform, one that's inexpensive, a non-invasive or minimally invasive test, something that discriminates colonization from infection, and something that distinguishes from non-infectious etiologies. Many patients who present with acute illness, whether it's respiratory illness or otherwise, don't have an infection at all. They may be coming in with allergic rhinitis or allergy-related symptoms. They may be coming in with heart failure, with costochondritis, with postnasal drip, acid reflux. there's a very large list of conditions that are non-infectious that can mimic the symptoms that you would see in someone with a bacterial or a viral infection. So an ideal biomarker is one that can also distinguish non-infectious disease from infectious disease. Well, let's talk a little bit about some of these biomarkers. Probably the one that is receiving the most attention and is available for clinical use in the US as well as in Europe is procalcitonin. Procalcitonin is a precursor of calcitonin, which most of you may recognize as being involved in calcium metabolism and homeostasis. The parathyroid normally produces PCT and converts it to calcitonin for calcium-related biology. However, procalcitonin is also produced by other cells, and in particular, under a normal healthy situation, levels are quite low in the serum, less than 0.05 nanograms per mil. But in the context of bacterial infection, procalcitonin production is stimulated not just in the parathyroid, but by numerous tissues in the body to lead to very high levels. And in the most severe illness cases, such as septic shock, you can see greater than 1,000-fold increases in procalcitonin concentrations. The kinetics of it are useful for identifying etiologies of acute illness. And so here, for example, you see some early inflammatory markers, IL-6, IL-10, TNF, rising within a couple of hours of exposure. In this case, these were controlled experiments where the exposure to the pathogen, or LPS, was given at a particular known time. You see procalcitonin levels starting to rise at around 6 hours and peaking at about 24 hours. And then they start to decline, assuming that the stimulus for procalcitonin's releases is gone as well. CRP rises a little bit later. You start to see increases in that at about 12 hours, peaking at about 24 to 48 hours, and then starting to decline thereafter. So PCT does tend to rise early, which is very useful. After treating an infection, in this case, again, these were also experimental conditions, procalcitonin rises quickly, and then once the infection is treated, the decline is a little bit slower. In this case, a half-life was estimated at just about 24 hours. So measuring procalcitonin on a daily basis, for example, for hospitalized patients to track infection is very conducive to this particular half-life of 22.5 hours, 24 hours, in order to assess response to treatment. A number of trials have been performed to evaluate procalcitonin, and historically the way that most of them have been done is to use an algorithm. And this is the algorithm that's been used. And this is specifically for respiratory tract infection. There are similar trials that have been done for sepsis. Those have slightly different cutoff values. But for respiratory tract infections, a PCT value that is less than 0.25, this group here, is a scenario in which antibiotics are discouraged. And there's just this division. If procalcitonin levels are very low, less than 0.1, antibiotics are strongly discouraged. If it's low, but still a little bit of a higher range, there's still a recommendation not to give antibiotics. And among inpatients, and if antibiotics are withheld, there's a recommendation to repeat the procalcitonin within 6 to 24 hours, because it has been shown that sometimes false negatives can occur, particularly early in disease illness, despite the fact that procalcitonin levels can rise fairly quickly. Among outpatients, there's a recommendation to reassess or repeat testing, particularly if symptoms persist or worsen. And then antibiotic therapy should still be considered if the clinical context warrants it. In the other group, among patients with a high procalcitonin, depending on the level of increase, antibiotics are either encouraged or strongly encouraged. And then follow-up samples and measurements of procalcitonin can be obtained, such as daily, to help follow procalcitonin. And when those levels have fallen below a certain level, then it's been shown that antibiotics can be safely discontinued. In this particular study design, again, there have been quite a number of them, including meta-analyses that have looked at these. And that was recently reviewed in this Cochrane systematic review published at the end of 2017. There was also a patient-level meta-analysis that was published earlier this year in Lancet Respiratory Disease, I believe, Respiratory Medicine. But I'll highlight some of the key findings of this particular Cochrane review. And in this case, I'll first point your attention down to the bottom. One of the main reasons that procalcitonin is used is to try and more prudently use antibiotics, to identify those patients who need antibiotics and those who don't. And in studies in which the procalcitonin algorithm was available, and actually let me take a step back. I described the algorithm, but the way in which these studies were done is that patients were randomized to either have the procalcitonin result and the algorithm provided to the clinician, or to have the result, the procalcitonin concentration, remain blinded. And essentially the clinicians were then available or able to apply standard of care. And so it was really a determination as to whether or not the procalcitonin result coupled with the algorithm made a difference in clinical management. Clinicians were free to overrule the algorithm if they felt it appropriate. And in those rates in which the algorithm was overruled varied from study to study, but in some cases was quite high, close to around 40%. So having said that, going back to this meta-analysis, the antibiotic exposure in standard care was about 8 days. And in those in which procalcitonin was available, it was about 2.5 days less in terms of total antibiotic exposure. Much of that comes from patients who never had antibiotics started in the first place, but a lot of it is also contributed by patients who had antibiotics started, but then stopped based on low measurements or normalization of procalcitonin. Now, it's fine to reduce antibiotic exposure. I can decrease antibiotic use by 100% if I take your antibiotic away. But obviously the worry is that patients will end up having treatment failures. And we'll jump up here to the treatment failure part. What was actually found is that when physicians used procalcitonin and used the algorithm, there was no increase in the rate of treatment failures. And if anything, it almost looked as though there was a lower rate of treatment failures, though it failed to reach statistical significance. But the main thing there is to demonstrate that there was no increase in treatment failure. That was key. Now, highlighted by the blue ovals, that is antibiotic-related side effects. And this is the point here is that the reduction in antibiotic-related side effects was not trivial. That decreasing antibiotic exposure by that amount led to a significant reduction in antibiotic-related side effects. And one final point to make is, perhaps a little bit unexpected, is that if we are decreasing antibiotic exposure, it makes sense that you might see fewer side effects, but you wouldn't necessarily expect it to impact mortality. And the main reason these studies were looking at mortality was to make sure that decreased antibiotic use didn't increase mortality. And in fact, the opposite was observed. When procalcitonin was used and antibiotics were used more judiciously and appropriately, mortality was actually lower than it was in standard of care. And there are a number of different hypotheses as to why, but I don't think anyone specifically knows the reason. Perhaps it's simply the antibiotic-related side effects. Perhaps it's decreased antibiotic use and the effects that might have on the microbiome. There are a number of possibilities, but it's not quite clear. And it's also possible that some patients had antibiotics started that might have not had antibiotics administered in the first place. And so there may be some contribution of that group, although looking at these numbers, that tended not to happen very often. And so the meta-analysis that I described and the studies that went into it were used to support an application to the FDA in order to expand the indications for use for procalcitonin. And that was granted at the end of 2016, or that was discussed at the end of 2016 and then granted in the beginning of 2017. And the expanded indication for use with respect to lower respiratory tract infections is to aid in decision-making on antibiotic therapy for patients with suspected or confirmed lower respiratory tract infection, defined as community-acquired pneumonia, acute bronchitis, and acute exacerbation of COPD in an inpatient setting or an emergency department. And the rationale for highlighting inpatient or emergency department is the recognition that procalcitonin may not be accurate in and of itself to be the only determinant as to whether or not antibiotics should be prescribed, and it should really be used in conjunction with other testing such as white count, PCR assays for pathogens, radiography, or input from other clinicians. So that was why the decision was made to make this particular recommendation. Now, procalcitonin, I've showed you, can significantly reduce antibiotics and to do it safely, but there are some potential limitations. And this is one study that I think is very interesting because it comes back to the EPIC study, which we've now talked about a couple of times. And what it does is it asks what procalcitonin concentrations are in adults who are known to have community-acquired pneumonia. And specifically where the etiology of the pneumonia is presumed to be known based on all of the testing I described earlier with the EPIC study. This particular study, just to highlight, they started off with a fairly large group of patients and ultimately whittled that down to a subset of about 1,700 patients for whom procalcitonin concentrations were available. The majority of those, about 1,000 of them, did not have a pathogen identified. And again, that's the same as the 62% we saw earlier, where despite extensive microbiological testing, no pathogen was identified. But of the groups where a pathogen was identified, the focus in this study was on those who had a typical bacterial pathogen, which was 10%, an atypical bacterial pathogen, 4%, and a viral etiology, which was 24%. And what they found is, looking across these different groups, here what we're seeing is the procalcitonin concentrations in these different groups. And as you might expect, for patients with a viral infection, and just as an aside, the reason procalcitonin levels are low in viral infection is because viral infections tend to induce interferon as part of the immune response to viral infection, and interferon inhibits procalcitonin release. So that's the mechanism by which procalcitonin can differentiate bacterial from viral etiologies. What you can see here is that the viral cases tended to have low procalcitonin concentrations. However, there's quite a significant spread. You see quite a number of patients who have procalcitonin concentrations above 0.25, which would typically be the cutoff beyond which antibiotics would be recommended. And some patients have considered outliers, but nevertheless have procalcitonin concentrations well over 10 and even over 100. Interestingly, the atypical bacterial group looks very similar to those with viral infection. The average does tend to be a little bit higher, but you still see a lot of patients with atypical bacterial infections actually have low procalcitonin concentrations, below 0.25, more than half of them, in which case you would, based on procalcitonin alone, those are patients who would not receive antibiotic therapy. Among those with typical bacterial infections, the median procalcitonin level was 2.5, which was quite high, but nevertheless, a fair number of them still had low procalcitonin concentrations. And then what you can see here are the distributions for the mycobacterial and the unknown. Now, I'll highlight that for the unknown category, the concern is always that if you don't find the pathogen for a patient with pneumonia, is that, what does that mean? Could it be a bacteria that you're not finding? Could it be a virus? Could it be something else? And if you use procalcitonin as your guide, those patients appear to be most similar to the atypical bacteria or viral group, probably sort of an average of the two. So it may be that a lot of these cases of pneumonia with no microbiology are in fact viral or atypical in the sense that it is a bacterial pathogen, but not one of the typical ones that might be identified through conventional culture techniques. Also from this same paper, I'll highlight the fact that what they did is they went and they asked what would the performance characteristics of procalcitonin be if we applied the standard cutoff of 0.25, as well as some of other low cutoffs, 0.1 and 0.5. And if we go with the standard cutoff of 0.25, the sensitivity of procalcitonin to discriminate bacterial from viral infection, where a bacterial is defined as typical and atypical, you see a sensitivity and specificity of only about 66, 67%. That improves a little bit if you separate typical bacterial from other pathogens, where now your sensitivity goes up to 77%. But that would still end up excluding your atypical bacterial etiologies of pneumonia. So there's a little bit of a disconnect between this study and the procalcitonin algorithms and the meta-analysis I alluded to. in the sense procalcitonin here does not seem to be a good way of discriminating bacterial from viral infection, and yet using procalcitonin in an algorithmic way safely decreases antibiotic use and potentially improves patient outcomes. And so that leaves one to wonder why be. And again, there isn't a clear answer, but it's possible that certainly some patients with bacterial infections don't necessarily need antibiotics to get over them. And procalcitonin may be a good biomarker to help identify patients who need antibiotics, regardless of whether it's a bacterial infection or not, or don't need antibiotics. And again, highlights the value of the host response to infection over what pathogen detection strategies may identify alone. Another possible explanation is that procalcitonin, the studies that use those algorithms, there was an opportunity to overrule. And so if a patient had a clinical syndrome consistent with bacteria, but at low procalcitonin levels, those clinicians could overrule and still give antibiotic therapy. And so in those cases, a low procalcitonin didn't necessarily mean that the patient antibiotics. And that may explain some of the discrepancy between this study and the meta-analysis and the procalcitonin studies I alluded to. Now, some of the other limitations of procalcitonin that are worth pointing out is that you can get both false positives and false negatives. False positives in the case of some oncological processes, other inflammatory conditions that you see listed here. And false negatives can be seen in localized infection that just simply may not be enough to release procalcitonin early in the disease process in patients with steroid use or in atypical bacterial infections, as we just saw. And so one study that's currently being done in order to address this is a study called TRAP-LRTI. This is an NIH-sponsored study with support from bioMérieux. And in this case, the purpose of the study is to ask whether or not procalcitonin can identify patients for whom antibiotics are unnecessary. And this is different from the other studies in the sense that in the other algorithm-based studies that I described earlier, the procalcitonin measurement came along with an algorithm that gave recommendations, but clinicians were free to follow them or ignore them. In this case, the study is being done as a randomized non-inferiority study comparing placebo to azithromycin in patients with lower respiratory tract infection who have a low procalcitonin level. And so in a low PCT level in this case, there is no algorithm. The patients are simply assigned to antibiotic or not, and the primary outcome measure will be clinical improvement by day 5. This particular study design, to my knowledge, hasn't been done at a large scale. And so this will be the first to assess whether procalcitonin in and of itself can safely guide antibiotics offer no benefit over placebo. Moving beyond procalcitonin, another peptide-based host response biomarker is a test called ImmunoExpert. This is not available in the US, but has a CE mark in Europe. It's manufactured or made by a company called MeMed in Israel. And the way this was developed was to start with proteomics, meaning that there were a large number of different proteins that were measured in patients with bacterial or viral infection. And ultimately, a combination of 3 was identified. TRAIL, which tends to be increased in viral infection and lower in bacterial infection. IP10, which is elevated to a greater degree in viral infection. And then C-reactive protein, which tends to be elevated to a greater degree in patients with bacterial infection. And when you combine all 3 to generate a signature, what you can see in the panel on the right is you get pretty good discrimination between bacterial and viral cases, whereas either biomarker alone, you see some statistically significant separation, but probably not accurate enough in order to distinguish between these groups at a clinically relevant basis. Now, as it currently exists, this test is a moderate complexity test. It takes about an hour and a half to 2 hours to get to an answer. And again, it's currently only available through research partnerships. And the way that the test ultimately provides an answer is you get a score where a high score tends to indicate a bacterial infection, a low score a viral infection. And so it doesn't appear that this test would have the ability to identify independently a bacterial and a viral co-infection. There's also this equivocal group in the middle where the research that's been done with this particular biomarker kind of ignores those results and only focuses on those who have a clear bacterial or a clear viral call. So some of the strengths are that the numbers were shown to be better than procalcitonin. So we would assume that all of the advantages that procalcitonin offers would extend to this kind of a strategy as well, and perhaps even better. There is a rapid test that's being developed, but is not available as of yet. Another thing, a few other things to point out in terms of weaknesses is that there is some incorporation bias, meaning that that cases were determined to be bacterial or viral through an adjudication process, and that the adjudication process incorporated C-reactive protein. And so that can lead to some bias when CRP is both used to assign your reference standard and is also part of the test you're evaluating. The test itself, there was some demonstration of how it performed in patients with non-infectious illness, but by and large, it hasn't really been evaluated in that particular population. And then indeterminate or intermediate results, that middle group, which comprised about 15% of their test population, were discarded from the analysis and were not included in their calculations of sensitivity and specificity. So the numbers for sensitivity and specificity are likely to be lower when you actually evaluate them on every patient that was tested. But nevertheless, these values that even when you take that into account, offers a significant improvement over the current state of affairs and is equivalent, if not better, than procalcitonin. So certainly moving in the right direction. Now, this need to and motivation to generate bacterial versus viral discriminating tests was one that was highlighted in a prize, a challenge that was developed and supported by the NIH, CDC, and BARDA. And in this case, there were 10 semifinalists that were selected for the first phase of competition. There were a total of 3 phases of competition spread out over a few years. And there's a $20 million prize that ultimately supports these different participants. And there were a number of different strategies. Some of them were focused on detection of antimicrobial resistance, but some of them were focused on discrimination of bacterial and viral etiologies. And I'll highlight some work that we did ourselves that was one of those 10 groups that were selected. And it was developing host gene expression to classify viral and bacterial infection. And so this is a bit of a departure from current approaches because it focuses on the patient's gene expression to help discriminate etiologies. The underlying premise is that there are different immune responses depending on whether or not a patient is fighting off a bacterial, a viral, fungal infection, parasitic infection, or no infection. And we started off this lecture focusing on pathogen detection assays. We can also measure the immune response. And knowing that there are unique features of the immune response, we can then extrapolate from that and determine whether or not it is a bacterial, viral, or some other pathogen causing illness. So the way that we did this in a paper that was published now a couple of years ago was we generated 3 independent gene expression-based classifiers. One of them discriminated patients with bacterial acute respiratory illness versus alternatives, where the alternatives were either viral infection or no infection, a viral signature, and then a signature that discriminated patients with infection from those without. We then applied all 3 classifiers to a group of about 273 subjects, and we assumed that whatever the highest probability was, because again, there are 3 probabilities, that of a bacterial etiology, a viral etiology, or a non-infectious etiology, whatever the highest probability was, that determined the class. And that's demonstrated here. Our reference standard was a clinical adjudication, which is represented by the color. That dark blue, purple color are those who are determined to be bacterial. And if the test identified them as having a bacterial infection, it grouped them in the lower left part of the triangle. And so if you were viral, those were grouped in the top portion of the triangle. And if the test predicted a patient as having a non-infectious illness, those were in the bottom right portion of the triangle. So bacterial, bottom left, viral top, non-infectious, bottom right. And what you would expect to see or hope to see, and what you do see, is that the viral cases are clustering at the top where you would expect them to. The bacterial cases are clustering at the bottom left, and the non-infectious cases on the bottom right. Test isn't perfect. You do see some colors that are appearing in other areas. In some of those cases, we went back and realized that our clinical adjudication, which is by far not perfect, may very well have been wrong, given the new information that was provided by the patient's gene expression profile. But nevertheless, this was a promising approach. We compared this to procalcitonin and found that if the question was, does the patient have a viral infection or not, that a gene expression approach was pretty much the same as procalcitonin. But if the question was, does this patient have a bacterial infection or not, that's when we started to see improvements. And in particular, if the question was, does the patient have an infection of any kind or not, that's when we saw the greatest ability of these gene expression signatures over procalcitonin to make the right call. Well, these signatures are all well and good, but ultimately what we're trying to do is to get to a point where we have a test available for use. And so what's happened since then is some development work with two companies. I'll tell you about those very briefly. One of them is with BioFire, which we mentioned earlier, makes nucleic acid amplification tests for pathogen detection assays. The test itself is relatively simple to use, results in about 45 minutes, and can work direct from blood. And these were results that were presented at ASM in 2017. This is a preliminary version of a BioFire-based test that measures the patient's gene expression signature. In the top group are the viral results, and the bottom group are the bacterial results. The left panel is a box plot that highlights patients with viral infection versus non-viral etiologies, and that includes bacterial infections as well as patients who are sick without infection. And the numbers are hard to see, but on the top right is a ROC curve, and there a perfect test would give you an area under the curve of 1, and a useless test, a completely random test, would give you an area under the curve of 0.5. And we're seeing an area under the curve of 0.92, which is excellent in terms of infectious disease biomarkers. That's along the lines of what you might see with troponin or BNP, for example, in cardiovascular disease. In the bottom group, you see those cases of bacterial infection being discriminated from non-bacterial infection. The non-bacterial group was comprised of viral infection as well as non-infectious illness. And there you see an AUC of 0.87, a little bit lower than that of viral infection. Still, again, very good compared to what's currently available. This is what that looked like for just a random selection of patients that were tested. Those with an adjudicated viral infection are in that leftmost group, and they have high probabilities of having a viral infection, low probabilities of bacterial infection. You see the opposite result with the next group in the bacterial cases. And then if you were sick without infection and healthy controls, both ended up with low probabilities of both viral and bacterial infections. Another company that these gene expression assays have been developed with is Qvella. Qvella is not on the market, but they're generating a test that performs direct from blood pathogen detection assays. But their technology is conducive to measuring patients' gene expression signatures as well. And in some very preliminary data, there was an abstract at AMP in 2017 that just looked at 18 patients, and the different categories here are H for healthy, V for viral, B for bacterial, S for SIRS, which is a non-infectious illness. And you can see that there was only one mistake made, and that was a case of a patient with kidney stones who showed up as having a viral etiology. When we actually went back and looked at that case, even though the patient ultimately had a kidney stone, they were also reporting cold symptoms, runny nose, sore throat, but that was missed in the adjudication process. And so it's actually very likely that that patient did have a legitimate viral signature as well. There is some work that's going to be presented at an upcoming conference at ECCMID as well that further describes Qvella's development of a host gene expression-based tests. And so in conclusion, acute respiratory illness is one of the most common problems that patients seek care for from their providers, both inpatient and outpatient. Most most cases of acute respiratory illness are viral, and yet the majority of those patients end up getting antibiotics. Molecular pathogen detection assays are increasingly sensitive, but of variable and sometimes indeterminate significance that can vary from season to season. Procalcitonin has been shown to decrease antibiotic use and lead to better clinical outcomes. Newer host response peptide-based assays may improve on procalcitonin performance, and host gene expression is an entirely new domain for infectious disease diagnostics, with recent technical development that has enabled point-of-care availability, and is certainly an area to keep an eye out for in the coming years. Some of the research work that I've told you about has been done by a very large group of individuals. Again, this is some of the work that I alluded to at Duke. I won't go through and name them by name, but suffice it to say that it's been a very large collaboration, not just at Duke, but at multiple different centers. And from that perspective, we've been very grateful for everybody's participation and support. And so with that, I'll stop there and take questions.
Thank you, Dr. Tsalik, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. We'll answer as many questions as we have time for. Let's get started with our first question. The first question asks, given the discrepancy between procalcitonin levels and etiology of pneumonia, should this biomarker really be used to decide whether to give antibiotics?
Sure. So that's an excellent question. And I suppose it depends a little bit on the perspective that one takes. If the focus is on the correlation between procalcitonin and etiology, bacterial or viral, it doesn't seem to be a particularly great correlate. It's, again, better than anything that's currently available. However, I think the more relevant question is a clinical question, which is what happens to patients when you use procalcitonin? And that's been shown in a number of different contexts time after time to be able to decrease antibiotic exposure, which actually improves patient outcomes. Now, I don't think that it should be used in isolation of everything else. It is a biomarker, but we have to remember that biomarkers are not perfect. They're used to aid in the diagnosis of. And so if you have a patient who comes in with a syndrome that is very concerning for a bacterial pneumonia or a bacterial infection, and you have a low procalcitonin, I would probably go with the bulk of the evidence. If there's a white count of 20, the patient is hypoxic, there's an infiltrate on X-ray, there's purulent sputum production, no sick contacts, no viral symptoms like runny nose, sore throat, and it really looks to be consistent with a bacterial infection, but the PCT is low, I would still treat that patient with antibiotics. Just as much as you would if that same patient presented with a normal white blood cell count, but otherwise evidence of infection. So I wouldn't necessarily place more emphasis on any one particular parameter than any other, but in scenarios where there's uncertainty as to whether or not a patient needs antibiotics, which is often what drives a lot of antibiotic use, is this notion of, well, I think that this is probably viral, but I don't really have a way to show that, and I'd hate to be wrong, so I'm going to give antibiotics just in case. That's where a biomarker like procalcitonin can make a significant difference by getting rid of antibiotics for those patients where there really wasn't a compelling indication to give it in the first place, but now you have something that provides confidence in the decision to withhold antibiotics and treat the patient using other modalities. So I think ultimately, yes, procalcitonin is a biomarker that should be utilized, not indiscriminately, but use it appropriately and in the context of other clinical information.
Thank you for your answer. Our second question asks, when do you anticipate that multi-analyst host response biomarkers will be commercially available?
So we're still probably at least a couple years away. That development is ongoing, and The first step was generating the signatures, and certainly our research at Duke is not the only ones to have done that. There are a number of other groups that are working in that domain, and there are a number of other strategies to do so. The technology to be able to measure those signatures is the second component. And as I've shown you, there are at least a couple of examples, and there's certainly others that have the means to measure gene expression signatures reliably and quickly. And I think it's just a matter of getting those technologies fine-tuned, and then getting those studies done and through the regulatory hurdles that any diagnostic, any new test we need to overcome. I don't want, maybe going out on a limb, but I would say probably in 2 to 3 years is a very reasonable time frame to expect those sorts of tests for acute infectious disease to be available. There are a number of other gene expression-based tests that are available for other diseases, most notably for oncology. Those are send-out tests that you might not get a result back for days or weeks, in which case it's really not useful for infectious disease. So gene expression-based tests do already exist, but there aren't any that are currently available for infectious diseases. I think those are probably maybe 2 to 3 years away.
Okay, thank you so much for that information. Our next question asks, should all patients with acute respiratory infection be tested for viral pathogens? And if so, what test is most appropriate?
There's a lot of scenarios where testing is important. I would say a lot of scenarios where testing is unnecessary. And the recommendation I would give is to think about what you'll do with the test result before you even order the test. So if the test result, for example, is one that will tell you whether a patient has influenza or not, and based on that answer, you'll either give Tamiflu or you won't, or oseltamivir or you won't, then that's an appropriate patient to test. But if it's an outpatient who appears to have a cold, and your advice is going to be supportive care, acetaminophen, decongestants, throat lozenges, then testing won't change those recommendations. If, however, this is a hospitalized patient, someone who's much more ill, then an expanded respiratory panel is probably something that's appropriate and recommended. Right now, they're really only reliable antivirals for influenza, but there are other antivirals that are in development. And so knowing that there's a viral pathogen present will at some point in time have more direct relevance to treatment. But it can also tell you that a bacterial pathogen is not present and allow a patient, again, particularly in the inpatient population, to come off of antibacterials when they're not necessary. So for all patients, no. But for the right patient, yes, it can be an extremely important test to perform.
Excellent. Thank you for that answer. We have time for one last question today. And this question asks, are there advances in tests for bacterial pathogens in patients with respiratory tract infections?
Yeah, so the testing that I had described, most of it focused on viral pathogens. And part of that is because of where the sample is obtained. Most of these tests run on a nasopharyngeal or oropharyngeal swab. And most infections that affect the back of the nose and the back of the throat are viral in etiology. There are some exceptions to that. But when we think about lower respiratory tract infections like pneumonia, where people are most concerned about a bacterial etiology, it's unlikely that you're going to find that bacterial pathogen in the back of the throat. It's more likely to come from a lower respiratory sample. Now, there are tests that are being developed that use a lower respiratory specimen, whether it's sputum or bronchoalveolar lavage, for example, that do include a much larger number of bacterial pathogens. So there are tests that are being developed, molecular diagnostic tests focused on nucleic acid amplification that will target bacterial pathogens. But right now, they generally aren't available. The bacterial identification tests still largely focus on culture, and then some rapid antigen tests, as we've described with group A strep, as well as the urinary antigen tests. So in short, no, viral pathogens have a significant head start over bacterial testing, but hopefully that will change in the near future.
I would like to once again thank Dr. Tsalik for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through July of 2018. You will receive an email from LabRoots letting you know when the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again here at LabRoots. Goodbye.